Welcome to AETCM, the Emergency Medicine channel. A 52-year-old female came to the ER with alleged history of RTA, following which she was having a right arm pain and swelling. On primary assessment, airway was patent, she was speaking full sentences, breathing, saturation of 99% room air, respiratory rate of 18 per minute, circulation, BP was 160/90, heart rate of 92 beats per minute, capillary refill time was less than 2 seconds. She was having a pain score of 7/10. We gave injection PCM at this moment. Disability wise, GCS was E4, V5, M6, pupils bilaterally equally reactive, and patient was moving all 4 limbs. Exposure wise, she was afebrile. Warm blankets were given to prevent hypothermia. Adjuncts to the primary survey. Initially, we did an E-fast for the patient, which was negative. We also did a USG of the local region, since patient was having pain and swelling on the right arm. USG local region was done to look for any hematoma or any collection. There was no hematoma in the USG, but
that's not at all a adjoint to primary survey, right? See, primary survey adjoints are what? Primary survey adjoints are investigations that will let you decide whether you require immediate intervention or not. So, E-fast comes in primary survey because E-fast helps us to identify any intra-abdominal bleeding or pleural hemothorax, right? Any ultrasound that we have done later should not be mentioned in adjoints to primary survey. That you can say adjoints to secondary survey, isn't it?
VBG was done as an adjuncts. There was no acid-base abnormality, no electrolyte abnormality. Lactate was 2.7. CBC CRP point of care showed hemoglobin of 6.6 with a total counts of 9.8, platelet 3,92,000 and CRP of 0.9.
Okay. So with that VBG, how will you further go about?
Sir, VBG was showing lactate of 2.9 with a hemoglobin of 6.6,
okay,
which indicates patient might be going state of hypoperfusion. So patient might be having bleeding, which might have caused...
Patient might have hemorrhage. You can't say shock or hypoperfusion because your BP is quite high, right? What, 160 over 100, and heart rate is also 98 something. So very unlikely to be hypoperfused, but definitely patient's hemoglobin is alarming. So since you are having a alleged history of RTA, you should arrange blood then. Yes. You don't have to transfuse. You have more time to identify the source. But arrangement of blood products should be started from that point onwards. And 2 IV cannulas. Earlier you have put 1 IV cannula for PCM, but now with this you need 1 more, because if at all patient goes into further bleeding or any hypotension, you would want to manage with minimum 2 cannulas, right?
Okay. So at this point, 2-point PRBC was arranged. Coming to secondary survey, ample history, patient was having no allergy. She was not on any regular medications. Past medical history, she was a hypertensive patient. Last meal taken 3 hours back. Events leading to the RTA. 52-year-old female came to the ER with complaints of alleged history of RTA, where she was the passenger in the back seat of a car which went downhill a slope and hit a sand pile. The patient was seated behind the driver, and she caught the seat of the driver with her right hand, and that's when the impact, like when the car hit, she was holding on to the car seat of the driver. And following that, she had severe pain and swelling in that region. She could not lift the arm.
Where did she sit in the car?
She was in the middle. She was in the middle, but holding on to the...
What is another important factor you need to ask there?
She was not, seat belt was not there. She was
So,
not.
middle passenger not wearing seat belt is prone for what?
Ejection.
Ejection onto the anterior part of the car. So, patient can get ejected towards anterior part, hitting over the dashboard, can hit over the windshield. Gear knobs are there that can injure into the abdomen. So, these areas should be focused on this patient. Since patient is now saying she is having right upper limb pain, patient's concern and attention will be on right upper limb, and patient can miss mild fractures or abdominal contusion, which they may think it is trivial. Okay, so ejection injury feature should be asked. Easiest thing is to ask the patient, did you get ejected towards the front of the vehicle and you have to get up from the front to come back to your normal position? If patient says yes, we should suspect these conditions, isn't it?
On head-to-toe examination, head, there was no external injury. There was no history of loss of consciousness, vomiting, seizures, or any ENT.
Any head injury was there?
No, sir.
No head injury, right? So, head and scalp examination was normal. Okay.
Then coming to C-spine and neck, it was non-tender. Normal range of movement, and there was no neck swelling. Patient was moving all four limbs. Chest, there was no tenderness.
What type of injury do you expect in this patient who was sitting in the middle without seat belt, other than the ones that we already told? Anything in C-spine? Hyperflexion. Patient is going forward, patient doesn't have any restriction. Hyperextension comes when you have seat belts on. So this patient will most likely go forward due to inertia. So hyperflexion injuries can happen. So even if patient doesn't have tenderness of the cervical spine, you should check for
deficit.
Any upper limb weakness or upper limb paresthesias, you should check for any radiating pain. So if patient has any of these, you should suspect a spinal flexion injury causing spinal cord edema. It won't be there in spinal cord transaction or complete or incomplete transactions may not be there, but it can have edema due to the increased force.
Chest wise, there was no tenderness, air entry bilaterally equal, abdomen, it was soft, non-tender, bowel sounds are present, no contusion, guarding or rigidity. Pelvis, pelvic compression test was negative. Log roll we did, there was no spinal tenderness. Coming to musculoskeletal system, there was the right arm swelling was present, temperature was increased, sensations intact. But the patient was having paresthesia over the right shoulder. Range of movement was restricted, but distal radial pulse was palpable.
Okay. Range of movements of what was restricted? Shoulder joint or elbow joint? Elbow joint was restricted.
Elbow and shoulder both. She was having severe pain. She was not being able to lift.
Yeah, but passive elbow extension flexion was able to do?
Passive elbow extension.
Okay, why is that important? Now, let's come to the mechanism. What was the mechanism? Alleged history of RTA, while a non-seatbelt rider was keeping the hand over the driver seat, right? Backside of driver seat. So, basically a left upper limb injury, isn't it? Patient, car went to a sudden deceleration. Patient's inertia pushes the patient forward. What is the mechanism that is going to happen here?
So, there will be a direct blow to the shoulder.
Direct pressure transfer onto the shoulder joint. Since shoulder joint is inferiorly weak, a patient with the outstretched hand can get
dislocations.
Yeah, one is dislocation, preferably a posterior dislocation, isn't it? In this case, preferably a posterior dislocation. Patient can even have a head of humerus fracture. So when this patient complains of paresthesia of right shoulder, axillary nerve injury should be suspected, isn't it? Yes. And if axillary nerve injury is suspected, it can be answered with posterior dislocation. Its nerve can get stretched. Okay, that is one thing. What else can happen?
So patient can also have a shaft of humerus fracture.
Yes. Where in the shaft usually?
Commonly in the middle shaft.
Mid shaft due to the groove, right? Yeah. Due to that, mid-shaft fracture can occur. How will the patient present?
Patient symptoms will be pain, swelling, inability to lift the hand. Pain may radiate to the shoulder joint also. Along with that, we also have to look for any nerve injuries. We have to, if nerve injury, like to test for nerve injuries.
That will come. So basically, patient will have pain over
swelling.
the entire upper limb, but preferably over the upper limb rather than on the shoulder region. And patient will have restricted movements over right shoulder as well as elbow. Why? Because elbow flexion is by biceps brachialis, right? Since humerus fracture is there, patient will have pain on biceps contractions. So patient will not do even active elbow movements. So that may be the reason why you told that elbow movements are restricted. Okay. So these are the two things we suspect in this case: a posterior dislocation of humerus or mid-shaft fracture of humerus. Okay. So what are the complications we see when there is a mid-shaft fracture of humerus?
Mid-shaft fracture of humerus can either cause a nerve injury or vessel injury.
Okay. So, if it is a nerve injury, what are the most common nerves that can get injured?
So, most common nerve is radial nerve.
Okay. Because it goes through the groove.
Other nerves are median and ulnar nerve, but it's less common.
Okay. Can you describe the injuries caused by each of these nerves?
Radial nerve will basically supply the posterior compartment of the arm and the forearm.
Okay.
To test the radial nerve, if any deficit is there due to injury, then we have to ask the patient to make the thumb sign. You have to do like this and ask the patient to abduct against resistance. If the patient is able to do that, then the radial nerve is intact. To test for the and for the sensory loss, like motor function of the radial nerve, and for the sensory loss, we have to ask sensation between the thumb and the index finger. In between that, the web space. If,
that is a sensory isolated area of radial nerve between the index and thumb, right? This area. On the dorsal aspect, okay.
Then, sir, median nerve will cause weakness of the flexure muscles of the hand. So, we can test flexure policies.
So, if radial nerve is affected, what will be the posture of patient's hand?
So, wrist drop will be there.
So, first is that, no? First is patient will be unable to lift the wrist. So, wrist drop will be there.
Finger drop.
When you see wrist drop, immediately you have to suspect radial nerve injury and you ask the patient for first paresthesia or loss of sensation of the entire dorsal aspect of the forearm, especially on the first web space, followed by motor assessment. As you told, extensor hallucis function should be assessed with against resistance. Okay, now median nerve.
So next, median nerve. Median nerve, we assess the flexure muscles of the hand. So we can test the flexure pollicis longus of the thumb and the flexure digital profundus of the index finger. We ask the patient to make an OK sign, and if the patient is able to make it, and we then the median nerve is intact. The median nerve is intact. Then, sir, the ulnar nerve.
Sensations.
Sensations of the median nerve will be thumb,
lateral aspect of the
thumb,
two and a half
index finger and the middle finger. This first three fingers.
First, 3.5 fingers. 3.5 fingers. Small finger and ring fingers, half is by ulnar, rest is by radial nerve. So, index finger is the sensory area of middle finger, ventral aspect of middle finger, ring finger, sensory aspect of index finger is the sensory area of middle finger. You can check ventral aspect sensation for middle finger as such. Okay. Then, palmar area patient will be having paresthesia due to palmar branch of superficial palmar branch going as a cutaneous branch of median nerve before the carpal tunnel. No, that will also go. So patient will have paresthesia of all these areas with the Lateral, three and a half
3.5
fingers.
fingers.
What is the motor function?
Motor function is
Okay,
flexion.
sign. Okay, sign you told. Okay.
Then
When
sir,
ulnar nerve?
ulnar nerve will be, we have to check the dorsal and palmar interossi. For that, we'll ask the patient to adduct and abduct against against resistance. So if the patient is able to do, then the ulnar nerve is intact.
Okay.
And sensory wise, it will be the 1.5 fingers on the medial side.
Medial side. In that, the little finger is the sensory area. Okay. Then, so these are the common nerve injuries that you encounter, and this is how you check for them. Okay. So, if what you told vessel injuries also, no? What is the most common vessel injury that you encounter?
So brachial artery and radial artery.
Okay. Brachial
artery and
artery.
axillary artery.
Axillary artery. Yeah. If radial humeral head is involved, we are looking at axillary artery, or else it is brachial artery, right? Brachial artery injury is one of the common injuries. What else can happen?
Bleeding, sir.
Only artery is there?
No, sir. Venous oozing can also occur.
So, it is not only brachial artery, but vein can also get injured. One of the more common feature is vein to be injured, while artery is the one that almost all clinicians pick up, isn't it? How do you assess arterial injury?
Sir, arterial injury will, first of all, we'll have to measure the size of the, first of all, we'll get an ultrasound.
How you understand there is a vascular injury?
So first we'll palpate for the pulse.
Yeah, so distal pulsations, whether present or absent, is the biggest sign of a vessel injury, right? Arterial vessel injury. So that is when you get attuned to the fact that patient might be having a arterial injury. Then, so if you are having an arterial injury or even a venous injury, when do you suspect? If your peripheral pulses are there, you are getting both ulnar and radial peripheral pulses, but it's low volume or it's rapid thready that you are not able to assess the volume as such. It's very fast, heart rate is very fast. How do you further suspect patient might be having a slow bleed or oozing of blood from the vessel injury?
There will be rapid increase in the size of the swelling.
Not rapid, increase in size of the swelling will be there, isn't it? Okay. So how can you know that?
So we can measure
okay. Take an anatomical landmark and take a fixed measurement from there and measure the maximum point. If the maximum thickness point is increasing when you are repeating your measurement in 2 hours or 3 hours, you can understand that there is an ongoing bleed inside. Okay. How do you confirm the bleed?
If you are suspecting bleed, sir, then initially we can look with ultrasound if there is any hematoma.
So that's the easiest thing, ultrasound to rule out any subcutaneous or intramuscular hematoma. If it is there, we can acknowledge the volume of the hematoma and then repeat ultrasound periodically to check hematoma whether it's stabilizing or worsening. But if patient is rapidly increasing in size or complaining of severe pain or decrease in hemoglobin, decrease in blood pressure is there, what will you do then?
Go for CT angio, sir.
Go for a CT angio to see what type of vessel injury is there and whether it requires open reduction and this thing, plastic surgery, vascular surgery involvement also. Okay. So these are the common injuries that you encounter with the shaft of humerus fracture. Now, what are the types of fracture you encounter?
Sir, according to the AO North American classification, the fractures can be classified as A, B, C. A is simple, B is a wedge, and C is complex fracture, which means comminuted fracture. So that can be, and each simple wedge complex can be again classified into spiral, oblique, or transverse fractures.
That's okay. That much anyhow from emergency standpoint we don't want. So basically we can have the complex fractures is when you suspect associated nerve, muscle and vessel injuries, because there will be multiple fragments which can penetrate, isn't it? Okay, so how do you stabilize the patient's arm? Because when you are examining itself, you identify this fracture. Patient's arm is now against gravity there, no? So patient will have severe pain, restriction of movement. So you have to stabilize this for taking X-ray and other things. How can you stabilize the arm?
So we can stabilize the arm by putting a U slab.
U slab is for treatment, right? You give closed reduction and U slab for the stabilization of joint for discharging. You don't do that before taking X-ray, right? So in examination itself, you identify patient is having swelling, patient is having suspected fracture. You want to shift for X-ray, right?
We can just support the hand
Yeah,
with the
how?
splinting the
How do you splint this arm?
actually.
Either have a L-shaped splint or better is broad arm sling. You take a broad arm sling and put. This patient was put on broad arm sling, right? Isn't it? She was put on a narrow tie-based suspension from outside hospital. We changed it to broad arm sling. Means broad arm sling is put, patient's hand is not now lying against gravity. It is supported. You can shift for all X-rays and all. Then after that you can go for reduction. Then how do you manage?
Sir, management basically maximum of the humerus shaft of humerus fractures do not require surgical intervention. It is managed conservatively by putting U slab.
What are the contraindications to put U slab?
Sir, contraindications to put U slab will be if any open fracture is there.
Correct. So first of all, when you manage a fracture, question is, are you managing a closed fracture or a open fracture? All open fractures should be taken for in OT for open reduction and internal fixation to make sure patient doesn't develop any osteomyelitis. So that's the first thing. So closed fractures is the ones you try closed reduction with the U slab stabilization. In that, can you do complex fractures with the U slab stabilization?
Traction.
With traction, if multiple bone fragments are there, do you do this thing? No, that is, or else, let me rephrase my question. When a patient presents with a humerus fracture, when do you involve a orthopedician?
Sir, usually, first of all, if there is an open fracture, we have to immediately
inform.
Any vascular injury we are suspecting, then fractures involving the articular groove of the bone.
Okay.
Then, sir, if there is bilateral humerus fractures.
Okay.
Then, if there is pathological fractures.
Okay.
Then, sir, high velocity gunshot injuries.
Okay.
Then, sir,
that's because shattering of bone occurs, no?
Bone will be there. Sir, distal displaced spiral fracture of the shaft of humerus.
Okay, fine.
Then, sir, high fracture associated with radial nerve injury.
Any radial or vascular injury, you involve them for open reduction. Similarly, for complex fractures, you don't involve orthopedician.
Unstable fractures.
Yeah, so when you give traction and close reduction, you want the bone fragments to come together for ossification. But when there is a complex fracture, either the shaft is fractured into more than two pieces, or in two pieces there is multiple loose bone fragments which is floating. Not floating, it is suspended outside. So you don't take that for OT. What can happen? Any of these bone fragments can migrate and cause nerve injuries, vessel injuries later on. And when ossification happens, these bone fragments will be embedded inside the muscle or subcutaneous layer, causing painful movements for this patient. So complex fractures we need to inform orthopedician. Other fractures we can conservatively manage with the close traction and U slab stabilization. Okay. So post stab insertion application also, what will you check for?
This pulsations.
Peripheral neurological deficits or peripheral pulses you should look into. Now, how will you dispose this patient? You got a simple, think of a simple mid-shaft fracture patient. There was no complications, no vessel artery, vessel or nerve injury. X-ray shows simple, well undisplaced or minimally displaced fracture fragments. So you put use lab. How will you dispose this patient? Will you admit, discharge, or call ortho?
So we can dispose the patient and ask them to review in ortho OPD with painkillers which can discharge and ask them
What
to
do you give for pain?
NSAIDs.
NSAIDs as the baseline you should give, and according to patient's pain tolerance, you may have to hike up with additional analgesic tablets also. Okay, what else?
So after 1 week, they can start mild mobilization of the hand.
Yeah, when should they review in ortho?
So
Within a week, they need to review in ortho to recheck whether the close reduction has been successful and whether the body areas are in line ossification happening. If not, they have to redo the slab. So within a week they should review in ortho OP, and after reviewing they can continue physio and all. But within the first 48 hours they should start normal shoulder movements, that is anterior and posterior movements, and mild abduction movements of 10 degrees, 15 degrees they can start. They should refrain from doing internal and external rotatory movements of the shoulder joint. That is the one they should not do. But flexion extension movements and mild abduction movements of maybe 10 degrees and all, they can start within 48 hours to prevent non-use induced shoulder joint difficulties. Okay. So NSAIDs with extra analgesics, right? Okay. Anything else?